neonate. As many of you probably know, whether you have experience, a lot of experience in NICU or not a lot of experience in NICU, the majority of our admissions to the NICU are related to something respiratory, whether it's because they're premature or maybe we have a term baby that isn't breathing right or breathing fast or something. So early diagnosis of what's going on with the baby is very important so that we can get the correct course of treatment going quickly. And also, another important thing about NICU is that we can tell the parents what's going on, and we can give them a more realistic view of what's going on with their baby. If we could say, hey, you know what, your baby might just need to stay for a few hours to kind of get their breathing more regular, or maybe your baby has a respiratory distress syndrome and they're going to need surfactant therapy, for instance. So we're going to look at some of those today. We're going to choose two really common areas or diagnosis for respiratory in the neonate, and I'm going to divide you into two groups. And what we're going to do is divide you level 2 and level 3. So we'll have level 2 nurses on this side, level 3 nurses on this side, so you'll have to move around a little bit. And then I'm going to give you each a diagnosis to look at, and then you're going to come report back as a group. You can decide how you're going to do that to the class to tell us like distinguishing signs and symptoms of your particular diagnosis, and then also the treatment course for that diagnosis. So right now, if you'll go ahead and move to your groups, and I will give you your assignment.
Oh, don't say that. She's got plenty of things to take care of here. She don't need to right now.
She didn't hear that.
Come Olympics in 2030, average gymnast is 16 perfectly for the Olympics.
Okay, so we're going to start with the RDS group. If you guys will come up. And
we had respiratory distress syndrome, and I'm just going to talk about kind of what it's about. So RDS is immature lung anatomy. You have decreased surfactant, and it's like you're not the villi is not able to expand and it's unstable. Because surfactant is there to prevent the collapse of the villi, so it collapses without it. So you have increased work of breathing with RDS, and then I think that's it. So we're going to move on to signs and symptoms.
Okay, so things that you would find your patient presenting with cyanosis, apnea, so periods of not breathing, grunting. You're going to look at the nose, and you can see nasal flaring. Your baby's going to be tachypnic. You're going to see retractions. Of course, you can kind of look at the different types of retractions that the baby has, intercostal, subcostal. The breath sounds are going to be diminished when you're listening to the baby. You can possibly hear rales. The baby might possibly be hypotensive, so you can have decreased urine output. So you also want to look at your blood gas. You're going to have low oxygen. You're going to have excess acid when you get your results. So those are a couple of things that you can look at, and those are the signs and symptoms of RDS.
So for treatment, we're going to get a chest x-ray to rule out some other causes and signs and symptoms. We're going to get an ABG, CBG. We're going to do labs and cultures to rule out sepsis as the cause of respiratory distress. We're probably going to give some surfactant, some O2 support like bubble CPAP, regular CPAP, or possibly a vent. We're going to start trophic feedings and rule out PPA.
Any questions?
Okay, we had transient tachypnea of newborn, which is also called wet lung. Okay. Okay, the patho of this is the accumulation of interstitial fluid, and fluid interferes with forces that tend to keep the bronchioles open and eventually causes the bronchioles to collapse, which trapping air. It's a result of delayed reabsorption of normal lung fluid.
Okay, so signs and symptoms. You're going to get grunting, nasal flaring, retractions, cyanosis, an increased respiratory rate. Let's see, it starts between half an hour to 6 hours post-birth, and it's more likely in C-sections or in precipitous births because they don't have the time to compress their chest and get that fluid out. Let's see, you can also get a chest x-ray and it's going to show hyperinflation and streaky infiltrates from the hyla. And yeah.
For the treatment of transient tachypnea is we need to give supplemental oxygen to keep the oxygen saturation level more than 95%. And also we can keep the baby in vivo because of the chances of aspiration due to increased heart breathing rate. Also we can give IV fluids because the baby is in vivo. And we can probably start some antibiotics for the prophylaxis. And we can give some diuretics to eliminate the fluids. So.
Well, thank you guys for participating. That was, see, you guys learn a lot more when you have to find information on your own, right? So, we listened to both of your presentations, and did y'all notice that a lot of the signs and symptoms are very similar?
Yes.
So, how do you guys think when you're on a delivery, for instance, or y'all get a new baby in the level 2 nursery, how do you determine which, if your baby's just transit tachypnea and they're going to resolve in a few hours, or they might have full-blown RDS and might need to go to level 3 for further treatment or maybe surfactant therapy?
RDS is, in our article, inversely related to just the gestational age, so that age is important to do.
So if you guys heard Alicia, she said that RDS is inversely related to gestational age. So we know if we have a 30-weeker, for instance, or even lower, then most likely that is going to be RDS because we know they haven't had sufficient time to produce surfactant, right? So that's a great answer. What else? Because sometimes we see in these late pretermers, we'll see RDS. How do we differentiate? Okay, so cesarean birth, that's one good observation, that it might be a possibility. X-rays sometimes. And you know, the doctors are going to be there, and nurse practitioners to help us sort through all of these diagnostic tests that we're doing, from our CBGs to our X-rays. So you might hear doctors sometimes say, oh, they just have wet lungs, or maybe tell the parents that, and they're probably referring to, they think that the baby's going to improve over time, they probably just have TTN. But those of you who are experienced in NICU probably know that sometimes we might think that, and then a baby proves us otherwise. So my advice would be to continue to monitor your baby, and if the baby starts improving over time, then we tend to think it was probably just TTN. If they don't, and they continue to get worse without therapy, then we're going to ramp up our therapy and probably go ahead and assume that it is RDS. So those are just two of the main things that you guys are going to see a lot of in the NICU as you get experience. So remember, our babies kind of tell us what they need, and so we just have to kind of go with that. And sometimes, like we talked about, the parents are a big part of our care team, so helping them understand that sometimes right at the beginning we might not know if your baby's going to be here for 6 hours or if they're going to have to go to the ICU to be intubated, right? So kind of walking them through that process at the same time is very important for this. So thanks, guys.